This is the first presentation in chest disease about focal lung lesions, and will be in general. Prepared by Prof. Sharaf and revised by Prof. Yusriya Sabri. You remember this secondary lobule is that part containing some alveoli, and lymphatics can go through inside the elbow or in between secondary lobules. So we have interlobular and centrilobular, or what we called centrilobular and perilymphatic. Two lymphatic systems exist: central one along with the bronchivessels, and the peripheral one located in the interlobular septa. Here you can detect that centrilobular is concerned with the airways, while the perilymphatic is concerned with the fissures, interlobular septa, and the parenchymal, intersegmental septa, etc. So centrilobular involving regions around the bronchovascular markings could be pneumonitis and could be emphysema. Of course, pneumonitis means there is exudate, and that's why it is called exudative bronchiolitis, while emphysema is due to some obstruction or Bolan valve leading to inflation of the air spaces. Perilymphatic, again, as we said, along the interlobular, intralobular, and interlobular. The best example is the sarcoid, and lymphangitis carcinomatosa, as well as the famous distribution of edema within the fissures causing thickening. A lung opacity, or what we can say decreased radiolucency, may be well defined as a nodule or mass or pleural effusion. All of such things are well defined. Similar to pleural effusion is pleural calcifications, plaques, and mesothelioma. And similar to masses are the nodules, whether it is miliary, small nodules or large nodules, and soon we will know the difference between a nodule and a mass. These are examples of well-defined opacities, but still we have the second pattern of ill-defined opacity, ill-defined margins of opacities, as in collapse and fibrosis, or maybe something infiltrative. The best example is the consolidation, which is called airspace disease or alveolar disease, sometimes interstitial, showing both nodules and reticulations may be similar to infiltration, and finally in bronchiectasis. All of these are ill-defined lesions. Increased radiolucency are the reverse due to the presence of a cavity, a cyst, or bolla, or emphysema, or pneumothorax, or decreased volume of blood, as in pulmonary embolism. The main lung patterns are consolidation, and it could be segmental, it could be lobar, it could be diffuse, multifocal, multiple patches. Infiltrates or infiltrate is usually of ill-defined margins, starting as small nodules of ill-defined margins that coalesce together to form larger patches, and these larger patches may proceed to have segmental distribution, lobar distribution, or even lung distribution, whole lung distribution. This is consolidation, and we know that the best examples is due to replacement of the alveolar air with fluid, as in edema, pus as inflammation, or exudate as inflammatory process, transudation as in edema, and cells as in alveolar cell carcinoma. Number 2 is the atelectasis. Atelectasis means something deaerated, and thus there is reduced volume, and we should know the different pattern of volume reduction in every part of the lung. Then amongst the main lung patterns are the nodules or masses, and this according, if it is less than 3 cm it is a nodule, if it is more than 3 cm it is called mass, and even the nodules may be miliary, may be small, may be large. Usually most of the nodules is less than 2 cm, and this constitutes 80% of the nodules. Examples of nodules are metastasis, tuberculomata, hamartomata, AVM, etc. The fourth item is the cavity, the presence of cavities, bolli, cysts, and these cysts and cavities usually have wall, but bolli does not have and represent emphysema. Finally, the presence of interstitial disease is if it is reticular, interstitial, or both. Actually, this description of main lung pattern is the same as this one. Just the types of opacities or the types of how radiolucency is decreased. So it is either plural, either well-defined or ill-defined, and in well-defined we talked about masses and nodules and collections, and ill-defined we talked about collapse or atelectasis and consolidation, as well as interstitial disease. This is the collection of all. The presence of increased radiolucency is due to either cavity, air cyst with wall, bolla without wall as in emphysema, or pneumothorax or pulmonary embolism due to decreased blood flow. Now, what is the differential diagnosis of focal lung lesion, whether nodular or cavitary? Generally, we can group them into two main groups, granuloma and non-granuloma. If it is granulomatous, it could be infective or non-infective. If it is infective granuloma, of course, you go quickly towards TB and fungus, and if it is granulomatous non-infective, you can mention sarcoid, eosinophilic granuloma, and Wegener's granulomatosis. At the same sitting, we can mention about non-granulomatous lesions, non-granulomatous nodules, non-granulomatous cavitary lesions. If again infective, it would be either septic emboli or bronchopneumonia. If it is non-infective, it would be malignant deposits and infiltrates like thyroid carcinoma deposits or lymphoma or leukemia. Our job is to localize the lesion, whether it is in the chest wall, and how you can identify lesions in the chest wall. That means it is extrapulmonary. That means any mass involving the chest wall would produce an obtuse angle with the air inside the lung. Search for abnormal ribs, either congenital lesions, fractures, or metastases, multiple myeloma. Search for surgical emphysema, because sometimes after operative interference or intercostal tube placement you will find surgical emphysema. This is about the chest wall. For the lung, try to define its borders, its volume, its vascularity, and its radiolucency, and we discussed all of this in the radiological anatomy. For the pleura, please to identify again intra or extrapulmonary, and the same applies as any part in the chest wall. If it is something with obtuse angle, that means it is extrapulmonary. If it is with acute angle, try to exclude an intrapulmonary lesion first. The heart, remember the configuration of the heart and any abnormality as occurring in shunt with plethora or pulmonary artery dilatation or mitral valve disease, where you have left atrial appendix dilated with straightening of the left cardiac border and rounding of the heart, or it is a pericardial effusion as flask shaped of a heart. Then go to the mediastinum and check for unilateral abnormality or bilateral abnormality due to, for example, enlarged lymph nodes, and we discussed the mediastinum before in radiological anatomy and mediastinum. And try to localize if there is wide mediastinum, whether it is due to mass or aneurysm of the aorta or due to achalasia of the esophagus. Don't forget the hidden areas, like for example the APCs for Pankhurst, lower lobe pneumonias behind the cardiac shadow, or diaphragmatic recess deposit covered by the hump of the diaphragm. Try to apply our 666 and 3 rule for imaging any mass in the chest or outside the chest. Mention 6. First, the size, the site, the shape, the content, the surface, and surrounding. These are the 6 items to be discussed. Size, site, shape, content with calcification or cavity, surface, is it smooth or no, surrounding, compressed lung tissue around. Then mention 6 surroundings, meaningly the relations of the mass: anterior, posterior, superior, inferior, middle, and lateral. Then correlate with 6 pathology items you know all together from the pathology: idiopathic lesions, developmental lesion, trauma, inflammatory, tumor, and the group of miscellaneous. Try to correlate what you are seeing with any of these groups, and then try to give 3 common differential diagnoses. This is the rule of 6, 6, 6, and 3. A pulmonary nodule, as we know and just mentioned now, is an opacity of well-defined margin. It could be a starting carcinoma, and then we should definitely compare with previous or compare with coming films to elucidate the rate of growth. The size, if it is less than 3 cm, it is called a nodule. If it is larger than 3, it is called a mass. And as we said, 80% of nodules are below 2 centimeters. A nodule that is unchanged for 2 years is almost certainly benign. It wouldn't be malignant, because malignancy expect that the size is doubled every binary vision. Doubling, that's increasing the diameter of 25%, is equal to doubling volume in 6 to 12 months. This needs study. That means if the mass is doubled or its diameter is more than 25% increased, this is not that the volume is doubled. If this occurs within 6 to 12 months, this is a bad sign and indicate malignancy. If there are multiple, please search for and try to mention about metastasis. Nodules, if the calcification, this suggests benignancy, and it is present in 40% of nodules, especially if complete ring or central calcification. It is more with benign lesion. While calcified granuloma, for example, to have central popcorn or diffuse, or laminated as in tuberculoma, or central as in histoplasmoma, or popcorn as in hamartoma. So every pattern of calcification point to a special diagnosis. Carcinoid is punctate and eccentric. Calcifications are uncommon and seen in less than 10% in cases of carcinoid. Now, bronchogenic carcinoma may show irregular calcification, punctate calcification, eccentric calcification. As you see, the descriptions are all going to with irregularity. Irregular, punctate, eccentric should be considered suspicious if you find any of these types, and this need to be worked up further. 40% of nodules are carcinoma and 40% are granuloma, so we are in a situation which needs follow-up in most cases, except if the calcifications has a characteristic appearance like lamination, popcorn, or central. Now 40%, as we said, are due to carcinoma and 40% are due to granuloma. What about metastasis? If metastasis calcify, it will be diffuse and punctate, mottled. In this slide, we can get the whole thing. Calcification may be lamination, may be central, may be popcorn, may be complete, and this is due to benign lesions, while in malignancy it is usually eccentric or punctate, as in deposits coming from bone, for example, bone tumor. Nodules may be composed mainly of fat, and this is common in hamartomas. 50% is fatty and 30% is calcium. May be showing fluid, as in lung abscess or mucoid impaction, or bronchogenic cyst is a large nodule with fluid content, or it may be iodine, as in amiodarone toxicity, but this is known and history implies. What about the margins of the nodule? Smooth are benign, ill-defined, speculated, irregular, sun ray speculation is malignant. So smooth, well-defined margin is in benign nodules. Ill-defined or speculated margin is malignant nodule. Other signs include speculated margin in malignancy. If you find a pleural tail, that means malignancy. If you find acetylite nodules, other nodules, this would be TB. If you find a feeding vessel, of course, it's an AVM. If you find air crescent sign, that means that there is intracavitary air. If you find air bronchogram, that means it is a bronchoalveolar carcinoma. Nodule with air bronchogram is very dangerous and may suggest bronchoalveolar carcinoma. So again, if you find feeding vessel, it is feeding and draining cells and AVM. If you find more than one around each other and you exclude the deposit, please think of TB. If you find a pleural tail or speculated margin, this is more with malignancy. Speculated or ill-defined margins are more with malignancy. In tuberculoma, you can find dense calcification and you can find small satellites around, like here. In hamartoma, you can get what we call popcorn appearance. And in carcinoma, I think it is evident that it is a solitary, peripherally situated, speculated margin, and there is and the location is subpleural. This is the peripheral type of oncogenic carcinoma. Multiplicity are due to deposits, usually non-calcified round from 2 to 5 centimeter, and sometimes they are called cannonballs. May show the mass vessel sign, the tail, that vessel is going into the center of the nodule, and may show distal hypoperfusion. In miliary deposits, for example, the one on the right upper slide is an example of miliary deposits as the snowstorm of thyroid, and on the left is the cannonballs. But mind you that a deposit is not essentially a nodule. This is one of the presentations of deposits. We have the small miliary or larger cannonball or in between, but don't forget that deposits can represent as masses, like the two images down. So large masses, more than one, are also indicative of deposits. Here we have large, well-defined masses. There is no sun rays, there is no speculation. It has smooth outline, and smooth outline is benign lesions. So we have to go to the differential of tuberculoma, hamartoma, and hydatid or cyst. And of course, most common cause of cyst is hydatid cyst. It could be solitary in 75%, multiple in 25%. May show the water lily appearance or the halo sign or the air within the mass, the cyst, as in CT. You can see more than one layer. Germinal layers. You can see crumbled germinal layers inside the cutaneous layer. Of course, density is watery. Air may be seen, as we said, and we call it halo sign or meniscus sign. If perforation, it is hydropneumothorax. If rupture, we will find the germinal layer swimming on water, and this is called the water lily sign. These are hydatid cysts, hydatid in the chest, never calcify. Here are two examples of air-containing structures. One is a solid mass on the right, one is a solid mass with eccentric cavitary lesion. This is related to the central part of the lung, to the hilum, and this is definitely breaking in a malignant tumor, lung cancer. While the other one is a thin layer or well-defined, smooth outlined air space, and this is characteristic of an air nematocele, sometimes seen in some types of pneumonias. Thank you.